catastrophic catastrophic spending, and they'll tell you that about 52% of the households with a TB patient spend more than 20% of their income on health. Usually transport, food, nutrition supplements. Do we know this number for a household with a pregnant woman? How can we have good outcomes when we are throwing households into poverty? How can we have a high quality health system when whoever interacts with us is getting poor? So I'm sure going forward you'll be in favor of the different health financing discussions and options that the ministry is proposing to us, because these contribute to a high quality health system. Remember, I've said it's about the people. So I'm going to shift now, if this thing will allow. Okay, I'm shifting now to the confidence of the people. So I'll introduce something called the People's Voice Survey, which you heard about yesterday. This is the third part of the triad. People's confidence in the health system. How do we know if people are confident in the health system? In the private sector, you'll have seen that you're usually asked if you would recommend a product to a friend. Those who say yes are called promoters, and the net promoters, we get those when we subtract those who say no, they would not recommend the service, from those who say yes, they would recommend the service. So private sector always has a number of net promoters. If you visit them in their offices, they'll tell you. So look at the airlines graph on the bottom left. You'll see that the net promoters are on the x-axis. The y-axis shows you the 3-year growth. You see that for airlines, as net promoters increase, the 3-year growth increases. This trend is the same in other sectors, in internet and car rentals. So we expect the same trend in healthcare. What does growth mean? This means that more patients are using the services, they are adhering, they are retaining, they are happy, they are promoting, they are bringing their children, they are bringing their mothers, and so on. This is what industry means by growth. And I think this is what one of the areas that Professor Handa was talking about when he said we copy from the business community. So this is the type of data we see from the People's Voice Survey. We see that 70% of respondents in health do not endorse their health system. This is global, and even ask for major reforms. This is the same for high income countries. You can see the UK towards the bottom, the US, and even low income countries like Kenya and Ethiopia towards the top. So how are we surprised if people do not stay in care, or if they do not come, and we have to create multiple programs to make them come? So what is the number for Uganda? We will know once our country does the People's Voice Survey. So I'm shifting now from measurement. I've been talking about how you know that you have a high quality health system. Okay. I don't know how others have been doing this. So shifting from measurement to intervention. So if you know that the quality of your health system, you know the different measures. There are about 4 major areas to intervene. We know that the politicians are the entry point. You'll never get money for healthcare when the politicians are not on board. So the actually People's Voice Survey is designed to produce data that politicians respond to, and we can use it to bring them on board. But you cannot continue to do quality without scientifically bringing in political economics. That's important. And that's a thing I think we need to step up in our space. The second is service delivery redesign. I'll spend a little more time on this. Then there are finance innovations and payment options. We've seen the effect of using finance in RBF and so on. We've seen the effect on quality health systems. And of course, leadership and management, which multiple speakers have so far mentioned about. So I'll stay a lot with, I assume, I know we know these interventions, but we've not been seeing them as a package to create high quality health systems. Okay. So what is redesign? I'll stay with redesign because that's the one that's in our control as health, as a ministry. So we need to redesign to the right size the primary healthcare, the secondary healthcare, and the tertiary healthcare. And I hope the slides will be with you so you can read some of the details. But what we are saying is that what should be at each level should be correctly organized, because when we don't do that, we remain with problems. And I'm going to elaborate with maternal and newborn. And when I elaborate with maternal and newborn, it doesn't mean the other areas are any different. We just need to review them for the same. So this is data from Mbale region for the period October 2022 to September 2023. The bars are the number of health facilities. 101 facilities conduct less than 5 deliveries per month. 129 conduct less than 30 deliveries per month. So 54% of the 386 facilities in this region are very low volume for deliveries. This suggests that staff are thinly distributed, and staff at low volume facilities may not retain emergency skills. If you speak to people who handle mothers at delivery, one of the things they fear the most is an emergency. So this is when the adrenaline pumps and they need to do the right thing at that time. But if you've not seen a mother for the whole month and you're seeing them for the first time 4 weeks later, how are you going to remember what to do? This is the point I'm trying to make. This is not unique to Uganda, it's not unique to Mbale, it's just that this is the data I could find. So we need to think again about this. Have we designed in the first place correctly, or do we need to redesign? Okay, this one I'll spend a little more time on it because it has a key point that I'd like you to understand. The yellow row at the top lists some important maternal newborn health outcomes. The first row shows the percent of all pregnancies with that outcome, the first row below the yellow row. For example, 10% of all pregnancies are unplanned cesarean sections. What we have shown with the red part is the percent of deliveries with this bad outcome that were among low-risk pregnancies. This means, using the risks we know, we could not have predicted that these mothers could have had this bad outcome. Unplanned cesarean sections, stillbirths, newborn deaths, and so on. So this is happening, as you can see, it's 48, 56, and so on. It's happening for about half the patients across all the outcomes. So half the patients who have poor outcomes, we did not know that using the science we have, that they were going to have a poor outcome. Now we know what to do for the high-risk mothers, but now we are saying that half of them are low risk anyway. And this, of course, you have to remember that I've told you that 54% of low volume facilities, with 54% of low volume facilities, there's a good chance that this health worker receiving these mothers who are going to have these bad outcomes is in a facility that has not had a delivery for a month. So this is really the type of data that will force us to redesign. So I tried to the previous data was from other countries. I tried to pull comparable data from DHIS2, and you can see that in Uganda, about 50% of the maternal deaths occur in mothers with low-risk pregnancies. This is the same as the global data. While about 57% of the perinatal deaths occur among babies born to mothers with low-risk pregnancies. So with so many low-volume facilities, there's a good chance, again, that a health worker who has lost their emergency skills is handling our mothers and our sisters and our wives with the current health system. And again, we have to remember, if this will move, yes. Yes, we have to remember that the commonest cause of death is hemorrhage. So sitting where you are, imagine a midwife in a facility receiving a mother who is low risk. She has no clue that this is not a grand multipara. This is not a person in the previous car. They don't have all those things. What should she do when the mother in the process, because she just used the pathograph as we've trained them, and she's hoping the mother will have a normal delivery, and then they get this type of outcomes with hemorrhage. We know all the outcomes. We have very good audit system, so we know what most of them are facing. So this is where I'm glad we have the current chair, because I had asked him to pay attention to this slide. So what is our solution? Is referrals. We have a referral system for these mothers, not so? So Uganda, like other similar countries, again, everything I'm saying is not unique to Uganda. We rely on referrals. Only 14% of these low volume facilities, the low volume facilities, the 54%, have a functional ambulance in countries like ours. In Uganda, isn't the official location of the ambulance at the regional referral or the district? It's not even at the low volume facility. It's not theirs. But this is where the mother is, who needs the service. This is how we've designed it. No one is doing anything wrong, but this is how we've said we've designed our system. So the phone, we are saying that the midwife on call should make a phone call, but do we give them airtime? Aren't we relying on personal airtime in Uganda? Is it, I mean, hopefully that day they have airtime. I know you must have heard last year the story of the midwife who passed away at her own health facility. These are the circumstances. I mean, she's done her best within the guidelines, but the way we've designed the system is letting down some of our mothers. So I'll share now something about institutional maternal mortality by level of care, just again to show you how we are looking at the data to drive this point home. So we recognize, of course, that maternal mortality has improved tremendously from 336 to 189 deaths per 100,000. And even when you look at this 189, it's impressive. It's because of all the CQI we do. We've really pushed the maternal mortality down. But there are still some residual deaths. So what is the global space is talking about, these residual deaths. Even if you do everything you can within the current system, the way it is set up, some will still die. Yes, this is what this is what I call residual deaths. This is evidenced by the fact that in the past 4 years, institutional maternal mortality rate has been highest at regional referral hospitals. I know we know this statistic, but do we think of it in this from this angle? About 50% of maternal deaths occurred at regional referrals, and that 61% of these deaths were referrals in. So this is how we've designed it. The midwife finds the mother, gets PPH, call an ambulance, refer to regional referral, dies at the hospital. Not so. This is our current system. So of course the question is, are we ready to redesign, or we still feel we don't have money? Professor Hand has put across a very good presentation to say innovations don't need a lot of money. They need, as I said, they need political will, they need readiness on our side. So this is what some people are doing to solve that maternal problem. I decided to share it, not that I'm saying we should do it, but just so that we have some hope. So what some people are doing, I know in Kakamega County in Kenya, they are doing this. In a lot of European countries, they are doing it, and also in Ethiopia. So they are redesigning the maternal health system to move what I said earlier, right-size primary care and tertiary care. Here we say conditions that require a multidisciplinary team, first of all. One person cannot manage. Those conditions shouldn't be at primary level. They should be at the tertiary level, or even some of the secondary. Conditions that need a theater, should not be at primary health care. So should we be